Thank you very much for joining us today with this live panel discussion webinar titled Diagnosis and Management of Glaucoma Diseases, sponsored by NIDEK. I'm Keith Efford. I'm a sub-moderator from NIDEK, and it's very nice to meet you all. Today, I'd like to welcome Dr. Howard Barnebey, Dr. Jennifer Unger, and Dr. Dana Larouche to talk about glaucoma management with the NIDEK YC200S Plus YAG SLT laser, and what can it bring to your practice? After each presentation by the doctors, we would like to proceed to a further panel discussion on the contents of each of the doctors' cases, and then we'll answer some questions from the audience at the end. I now would like to introduce the moderator of the panel discussion, Dr. Howard Barnebey from the Specialty Eye Care Center in Bellevue, Washington. Dr. Barnebey?
Thanks, Keith. Welcome, everybody. Tonight, or wherever you are, it may be the morning or the afternoon, we want to talk about some new trends with glaucoma, not only diagnosing it, but also look at some new management trends. And hopefully you're going to pick up a couple pearls and we'll be able to generate some thoughts in a way which you didn't have before. But without going too much into detail, there has been a significant paradigm shift over the last 10 or 15 years, not only in how we diagnose glaucoma and the tools that we have, but also our management. And in particular, we've seen a significant acceptance and change with SLT laser as not only a component of glaucoma treatment, but also an initial treatment. We've also seen the introduction of new surgical techniques that are falling under the MIGS guideline, and hopefully we'll be able to address both of those. What we'd like to do this evening is to emphasize the importance of a multifactorial approach to not only diagnosing glaucoma, but also looking at different ways in which we can treat glaucoma better and provide a better service for our patients. We'll share some clinical experience with the new NIDEK YC200S laser. And with that introduction, why don't we just get started? Well, it's my pleasure to introduce Dr. Jennifer Unger, who is a comprehensive ophthalmologist in Appleton, Wisconsin, at the Valley Eye Associates.
Thank you, Dr. Barnebey, for the introduction, and welcome to Let's Talk About Glaucoma. I practice at Valley Eye Associates in Appleton, Wisconsin. I'm a comprehensive ophthalmologist who sees a lot of glaucoma patients, and I see new patients daily. In general, these patients need education about their condition as well as their treatment options. This is just a photograph of what it looks like in fall here where I live. It looks about the same in winter and spring. It is a little bit better in the summer. So after I examine my patients and diagnose them with glaucoma, I say these exact words: let's talk about glaucoma. And I pick up this black folder and a highlighter, and I open it. And among other things, it has some educational material contained within that I've written. This open angle glaucoma pamphlet is mine, and it lists the procedures that are currently available in my practice. Because there are so many options available to the glaucoma surgeon, I use 2 pages to list all of the procedures. Page 1 is the page that contains eye drops and laser surgery. So I show them page 1, and quickly after that, I show them page 2. The page 2 options are incisional surgery, including MIGS surgery and traditional approaches, tubes and trabs, as well as injections and oral medication that can sometimes be needed 4 times per day and may have a lot of side effects. By the time I've gone through page 2, we flip back to page 1. And at this point, patients are usually more interested in the page 1 options. And I discuss why I like page 1, and that's exactly what I say. I say there are no incisions, there's no trip to the operating room, there's very little risk, and they are very effective. And then additionally, I like to contrast the approaches of drops versus laser. Drops work very quickly, but they require daily, twice a day, 3 times a day, sometimes even 4 times a day use. There may be many side effects with eye drops, such as red eyes, irritation, allergies. With laser, on the other hand, results are delayed a couple of weeks, but the pressure lowering requires very little patient effort. The results may last years, and in fact, some treatments may be repeated. So after this discussion, we're ready to make a plan. And my 2 most common plans are here on this page, based on the Tmax, or the highest eye pressure that the patient has been measured at. For a pressure of 25 or less, I typically schedule SLT, and then after 2 to 6 weeks, if they are not at their target pressure, I'll consider adding eye drops or another MIGS procedure. If the pressure is 26 or higher, I still schedule SLT, but I also start eye drops to get the pressure lowered right away. Typically that's a PGA. And then I plan on discontinuing eye drops 2 to 6 weeks post-operatively. So the next question is, why is SLT my go-to laser? There's a number of reasons. I really do like using SLT over eye drops. One is that SLT lowers the pressure by 20 to 25%, making its results equal to that of a prostaglandin analog. And SLT can do this effectively 80% of the time. It is also safe, it's repeatable, and the results may last 1 to 5 years. I especially like it that SLT preserves the anatomy of the angle, preserving it for future MIGS procedures should the patient need that in the future. Finally, I've seen a couple of pressure spikes, but very few in my practice using SLT with the NIDEK SLT and my SLT protocol. My SLT protocol and my preferences include this laser, which is the NIDEK YC200S Plus. I like to pre-treat with pilocarpine eye drops, and then I use the Latina SLT lens to complete the laser. My post-op drops are a topical NSAID, used either 1 time a day or 3 times a day, depending on the type that is chosen. My treatment settings are as follows. I start at 0.4 millijoules, and I gradually increase the power until I observe micro bubbles. Then I back off a notch, which is 0.1 millijoules. For most patients, I'll apply 100 non-overlapping adjacent treatment spots over 360 degrees. For pigment dispersion glaucoma patients, I only apply 50, and I treat 180 degrees in an effort to avoid pressure spikes. But most cases, I do treat 360 degrees. There are several reasons why I have chosen to use the NIDEK YC200S Plus. Actually, there are 3 that I'll talk about in particular. The first one is the crisp edges that I see with the aiming beam. Both the aiming beam and the illumination beam, here's the picture of the illumination beam actually taken through my iPhone, are very clear at the same time. And this means that I can confidently place laser exactly where I want it, because I have a great view of the angle, and I also have a great view of the aiming beam. This makes for a very efficient treatment with SLT. I also like the larger cone size of the NIDEK YC200S Plus. And I like this because the laser energy goes through a larger area on the cornea, resulting in lower energy density. This concept is a bit easier to understand if we just recall some basic geometry. The area of a circle equals pi r squared. So a wider cone means that the energy is distributed over an exponentially larger area on the cornea. So this makes the NIDEK laser, in fact, the kinder, gentler laser, which is what we often refer to SLT as the kinder, gentler laser. But this laser is, in fact, a kinder, gentler laser with the larger cone size. Finally, I do like the control panel. The control panel is great. It's very easy to use. It's a touch screen, and it has a feature that is called SLT Navi. During the treatment that I gave this patient, here's the beginning. I'm ready to go, 0 spots fired. Here, I'm about halfway through, and I gave the patient a break here so I could take this photograph. You can see I have treated from 6 o'clock to about 12:30 or so. I've applied 50 spots of laser at 1.0 millijoules. Here I've finished the laser and I've done 100 spots, and you can see I've gone all the way around. In this particular patient, this patient had a lighter trabecular meshwork, which is why I'm using a 1.0 millijoule energy. That's a bit higher than I typically use for most patients who have more pigment in their trabecular meshwork. So in summary, educating patients about their glaucoma is a very important part of my practice. I believe that patients deserve to at least broadly understand their treatment options, even the treatment options that I think that they may never need, like MIGS, traditional surgery, injections, acetazolamide. I believe that the knowledge on my page 2 options helps the patient feel more comfortable with the page 1, and also informs them toward what may happen on down the line. 5-10 years down the line, they may need some different type of treatment. But page 1 has the drops and laser, which are the safer options. And finally, SLT is just an integral part of my glaucoma practice. And the NIDEK technology is often my first choice of treatment for these patients. So I will leave you today with some beautiful images. This picture here is actually summer in Wisconsin, which is the one non-white season where I live. Also a picture of my 2 children, Claire and Ava, in their concert black after their recent jazz concert. And then finally, I think this is a really nice drawing of the globe that I found in a 1960s textbook written by Newell. Thank you very much for attending.
Jennifer, thank you for that fantastic presentation. Now, let's hear from Dr. Daniel Larouche. Daniel is the Director of the Glaucoma Services and President of Advanced Eye Care of New York. Daniel?
Okay, good evening, everyone, and thank you, Dr. Barnebey, for the introduction. I'm going to be talking about SLT after cataract extraction and MIGS in patients with glaucoma. Glaucoma is the leading cause of irreversible blindness in the world, with an estimated global burden of over 64 million people that is projected to increase to 111 million by 2040. Currently, the only modifiable risk factor for glaucoma is intraocular pressure, and lowering intraocular pressure is the mainstay of treatment to date. The age-related enlarging of the lens is the most identifiable cause of glaucoma. You can see here with age, the diameter of the lens stays the same, but the lens thickness increases with age. Both lens size and IOP increase with age. The mean normal intraocular pressure is 15. The mean intraocular pressure in untreated glaucoma is 18, not 21. So in people with pressures of 18 or higher, it's very important to do gonioscopy. They also often show increased pigmentation. You can see increased pigmentation in the superior angle, but more so in the inferior angle, indicating pigment liberation from the enlarged lens rubbing up against the iris. Also, you can see narrowing of the angle and obstruction of the trabecular meshwork, leading to angle closure as well. There are exceptions to this based on corneal thickness and corneal hysteresis, but at pressures over 15 overall, you don't really get visual field progression. As the pressure increases and corneal hysteresis decreases, you'll have increased progression of visual field deterioration that can occur. In the LIGHT trial, the 6-year data SLT did better than eye drops for drop-free disease control. 70% of patients that underwent SLT were drop-free at 60 years. Both eye drop and SLT patients, however, did have progression of glaucoma that could occur. The SLT patients did much better than the eye drop patients, but both groups did have some progression. The eye drop patients progressed at 26.8%, SLT patients only 19.7%. And then the eye drop group had more disease progression. The need for more trabeculectomies, nearly twice as much at 5.6% compared to 2.4%, and a greater need for cataract surgery, 92 eyes compared to 59 eyes, nearly twice as much. So what else happens over age 50? At age 50, you can see that the prevalence of cataract starts to increase in addition to increasing the thickness and size of the lens. And you can see here also glaucoma starts to increase. The prevalence of glaucoma increases in all continents, in Asia, Africa, Europe, North America, Latin America, and the Caribbean, and in all ethnic groups, the European ancestry, African ancestry, Hispanic, and Asian. The highest groups tend to be in Latin America and the Caribbean and Africa, and the African ancestry, because both parts of those worlds have the least access to cataract surgery. And when you're looking at these patients, when you look at them clinically, and you look at the lens, if you see pigment on the lens annuals on a lens like this, be very suspicious of pigment liberation taking place and large lens in the eye, contributing to elevated intraocular pressure and possibly glaucoma. This is a video here of Schlemm's canal and the trabecular meshwork. And you can see the normal dynamic activity that occurs with the cardiac cycle. With the cardiac cycle, you have a pumping outflow of aqueous through the trabecular meshwork and the Schlemm's canal. We want to preserve that anatomy. Now, what happens during the thickening of the lens that occurs with aging and accommodation? Here you can see with accommodation, you have posterior bowing of the iris, increased thickness of the lens that occurred during accommodation, increased iridozonular contact that leads to increased pigment liberation that can block the trabecular meshwork, okay? And what you will see with aging in these patients, you'll see increased pigmentation of the trabecular meshwork that can occur, that can lead to lowering of the intraocular pressure. And if you look at the iris here, the iris is flat. It's not concave like in pigmentary glaucoma. And this angle is open. You can see pigment on the zonules over here as well. And what happens as glaucoma tends to get worse, you have increased thickening of the trabecular meshwork, decreased contractility of Schlemm's canal. This is a more mild form of glaucoma. And more advanced glaucoma, you have worsening thickening of the trabecular meshwork and narrowing of Schlemm's canal as well. So we have to rethink our approach to glaucoma. And my approach to glaucoma has really evolved to a new surgical algorithm. With early cataract surgery, when you take the cataract out, you can see the angle opens up here and you eliminate the iridolenticular contact that's present there. When you place a thinner, smaller intraocular lens, there's no longer any iris lens rubbing or iridozonular rubbing, and the angle is much more open. And cataract surgery alone can lower the intraocular pressure from 13 to 73%. And cataract surgery has been shown to be more effective in angle closure than laser iridotomy. You can see here the incidence of angle closure glaucoma is declining in areas of the world, and this is from Taiwan and England, that have increased access to phacoemulsification and cataract surgery as well. And so in addition to doing earlier cataract surgery, in patients with glaucoma, I like to do stents. This is a patient with a hydrostent, and you have scaffolding of Schlemm's canal to keep the canal open and bypass that pigmented obstruction of the trabecular meshwork to help lower the intraocular pressure. And recent 5-year data, post-hoc visual field, looking at the visual field of these patients at 5 years out, showed that patients who had cataract surgery and hydrus compared to cataract surgery alone had a 47% decrease in visual field progression with a mean dB of minus 0.26 dB per year compared to 0.49 dB in the cataract extraction group alone. Also, 66% of patients with hydrus are medication-free at 5 years, a much greater amount of patients medication-free. And they also had reduced risk of reoperation, with 2.8 times less likely to have glaucoma surgery requiring trabeculectomy or tube shunts compared to the cataract surgery group alone. And you can see the trends of MIGS are increasing from 2013 to 2018, and the amount of trabeculectomy and glaucoma tube shunts have been decreasing. And MIGS, this is data from the US Iris Registry 2013-2018. They have a very low rate of complications. It's often self-limited. The most common things that you can see are corneal edema, hyphema, iridocyclitis, and that's usually self-limited within the first to second week post-operatively treated with steroids and healing. Now, standalone MIGS alone without cataract extraction are much more likely to fail. 25% of eyes required reoperation at 2 years. So it's really important to take the lens out when possible, to increase the success rate of MIGS. And also, Black patients with moderate to advanced glaucoma had higher baseline IOPs, are more likely to require secondary surgery after MIGS. So you really want to catch Black patients as early as possible to help improve the success rate of cataract extraction and MIGS. And this recent study showed the association of prolonged use of anti-glaucoma medications with the surgical failure of ab internal microhook trabeculotomy that showed that patients who have been on medications for more than 4.5 years had a lower success rate of ab internal trabeculotomy MIGS. So the longer someone's on medications, the longer you wait, the lower the success rate is. So you want to intervene with this as early as possible to preserve the anatomy of Schlemm's canal, the trabecular meshwork, and the dynamic activity to pump aqueous out of the eye. Now, we also have some data on SLT. This is a study that looked at the effect of prior cataract surgery on long-term outcomes of selective laser trabeculoplasty. And you can see here, you can get as much as a 25 to 26% reduction of intraocular pressure at 30 months out of doing SLT after cataract surgery and MIGS. This one also is after cataract surgery alone. This is a study of 38 patients 12 months out. And you can see here, baseline IOP was 13.51. And at 12 months, IOP decreased to 10.05. And at baseline, the amount of medication is 1.71. And at 12 months, decreased to 0.41, a threefold decrease in medication use. And this is after cataract surgery alone. And now we're starting to see some data of SLT after cataract surgery and MIGS. In this study, the pre-SLT IOP was 15.94, post-LT IOP was 13.71, and the amount of medication was reduced from 1.67 to 0.73, and this was after cataract surgery and iStent. And this is another study that was presented at ASCRS 2021 by Dr. Richard Leher, looking at about 50 patients who underwent SLT after cataract extraction and iStent. And at 12 months after SLT, the IOP is reduced by about 22.7% in eyes with medications and 24.2% in eyes without medications. And the mean time to adding a medication is about 12 months after SLT. So even after cataract extraction and MIGS, some of these patients will still need additional treatment, and SLT works very well in these patients as well. 22.8% of patients who underwent primary surgery with iStent and phaco underwent SLT. SLT occurred at a mean of about 29 months after primary surgery, and repeat SLT in 7 eyes had a 71.4% success rate. So you could even repeat it in these patients as well. So basically, consider earlier cataract surgery and refractive lensectomy and MIGS to enhance the success rate of these procedures. The longer the patient's on medical therapy, this reduces his chance of cataract extraction and MIGS. SLT is very effective before and after cataract extraction and iStents. SLT can reduce both medication burden and IOP after cataract extraction alone and cataract extraction with iStent. Further studies are needed as we continue to progress in this new MIGS environment as well. Thank you very much.
Daniel, thanks for a fantastic presentation. Finally, let me introduce myself. I'm Howard Barnebey. I'm a glaucoma specialist in Seattle, Washington. And what I would like to share with you is my initial clinical experience with the new NIDEK YC200S plus laser. And the question that I had a couple of years ago was, why do we need another SLT laser? Is it going to be the same as other ones on the market, or will there be some differences or enhancements that will make this particular laser and the design and functionality more appealing to me as well as hopefully to you. So when I look at something better, I want to look at engineering that may be better. And I also want to look at the features that would be appealing to all of us. And the features I'm thinking about would be greater precision, better control, better functionality, doing the particular laser applications that we like. And when we look at engineering, these are the things that really we don't think that much about, but we count on them. We count on a laser that is going to function and deliver a good consistent energy beam. We're looking at a control panel that is easy to operate and lets us make changes on the fly as often we need to do when we do a treatment. I'm looking at good optics, that lets me see the structures I need to see. And also I'm looking at a good, well-designed ergonomic delivery platform that makes it easy for us. And we don't really think that much about the laser and the beam energy that comes out and the consistency of it. But we want to, have a device that, can deliver a good, even distribution of energy on the tissues that we're treating. And then finally, we want to have a platform which is stable. We'd like to have something that requires minimal upkeep, and also, be a solid state quality machine. What I like about this laser is the control panel, the ability to look at the control panels. It's very intuitive, and the safeguards that I have to make sure that I'm delivering the right laser, the right energy at the right settings for us. Optically, the optics are superb. It's what I would expect from a high quality slit lamp, and that's what we get. We have an adjustable illumination tower that helps us, visualize structures. Sometimes, it's not as easy as we would like, and having an adjustable illumination tower makes it easier. We want to have something that is comfortable for us to do the procedure, and not only for us, but also for the patient. So we'd like to have something which is comfortable. So, as a reminder, when we do an SLT laser, we're treating with a 400 micron spot size. We're treating the entire trabecular meshwork with contiguous applications. And when you think about, the average corneal width, the average circumference of the trabecular meshwork, then to do this, you're on average putting in between 95 and 100 applications. And that's exactly what we did, with our initial experience treating patients. And so what I'd like to share with you is the initial experience we had with 54 patients. We took really all comers. They had to have open angle glaucoma. Some were on medicines, some were naive to treatment. And we used a consistent, similar protocol. Initially, I only placed 80 applications in, but toward the end, we were very consistent with 100 applications. We treated 360 degrees as a single setting. And we used a program that NIDEK has incorporated in the laser called NAVI, which helps me evenly distribute the laser applications throughout the 360-degree circumference. And what I'd like to do is to share with you not only the 3-month data, but also the 6-month data that we have. And during this period of time, we didn't change any medications. So if a patient started out and they were on 2 medicines, throughout that same period of time, they were on 2 medicines, and so on and so forth with people who were naive. So the first slide is a scatter plot, and I'm just going to put a line in there that you can use to look at comparing at the abscissa at the bottom. We're looking at the baseline pressure in millimeters of mercury. And the vertical meridian is the post-laser pressure at 6 months. And if you look at the regression line, which is would reflect really no effect, not making it better or not making it worse. The majority of the patients that we treated were below that red line, indicating that the pressures were much better after the treatment compared to before. And that's exactly what you would expect with any SLT laser treatment. We also compared the 3-month data to the 6-month data. And in this histogram, you can look at the percentage of reduction. And I'm not sure if my pointer is working for you, but if you look at 0, that would represent that it's no better, no worse. And that where there be 0.2, that's a 20% reduction in pressure. 0.4 would be a 40% reduction in pressure. In a similar manner, if you had a minus 0.2, that would be a 20% increase in pressure. So not everybody had a perfect result, but the vast majority did. And if you look at the 6-month data, you can see the majority of people had a decrease in pressure that averaged around 17%. And there were some people that had a fantastic 40% reduction. So overall, the clinical experience was quite good. We broke down the information a little bit differently and looked at the average percentage reduction. If you looked at the number of patients that had a reduction of 15%, that was clinically significant. But we also had patients where there was a 11 to 20% reduction, 21 to 40% reduction, and a couple patients with a 40 to 50% reduction. And that's a reflection of the histogram that we're seeing on the right-hand part of the slide. But overall, we had, if you take all the patients, a little bit more than a 15% reduction in intraocular pressure. So to summarize, this is the first clinical study with a new NIDEK SLT laser. The efficacy is comparable to other published studies. My experience is that it's a very intuitive, well laid out, ergonomically comfortable laser to work with, and it has superb safety controls. Okay, well, we've covered a lot of territory in a short period of time. I'd like to open up some discussion among the panelists, and then we also want to encourage any questions that you may have, to either text them in, chat them in, and we'll do the best we can to answer as many as possible. One of the questions that I had, and I'll ask it initially to Dr. Unger, is do you have any difficulty with patients buying into laser as an additional or initial treatment, or is there some pushback?
So yeah, that's a really great question. My patients tend to go for laser when I recommend it. So I have a high conversion rate, but I think it's the way that I present it and the fact that I truly believe when I recommend something, I truly believe that that's in the patient's best interest. And I think they sense that from me. So I think that's very helpful if the doctor really, believes in their treatment. There are always patients though, who they're just resistant to treatments. I had one today, just really is not interested in laser, and you get a sense for that, and there's really no convincing them. So, and I think that's okay. Then I just carry on with eye drops.
Okay, great. Hey, Dan, what's it like in New York? Is it different? Are you able to persuade everybody to have laser from the get-go, or is this something where there's some pushback there as well?
Well, I have diagrams and pictures of some of the pictures I showed in my presentation of the enlarging lens and pigment obstructing the trabecular meshwork. Can you hear me?
I can hear you.
Okay, good. Pigment blocking the trabecular meshwork. And in the majority of my patients that I see, particularly over the age of 50, I describe that as the mechanism of the obstruction of the trabecular meshwork that's causing their pressure to go up. And I'll give them 3 options. Earlier cataract surgery and MIGS, which is what I like to go to initially, SLT, and eye drops. And so And I let them know, like with the eye drops and SLT, it doesn't really fully address that mechanism. Taking the lens out and doing the MIGS addresses more the mechanism. You get a greater bang for your buck. So I like to go with that first. But some patients don't want to do incisional surgery right away. They prefer either a laser option or eye drop option. If someone needs 2 eye drops and they have side effects like redness in the eye or forget the eye drops, then they're more likely to move to the SLT in that respects. When I do work internationally and in underserved areas, if they have an SLT machine, we like to do that first because they don't have access as much to phacoemulsification and skilled micro-incisional surgery. And so you want to delay that because they're doing, a manual small incision cataract surgery, which is a much wider wound. And so since you don't have that type of skills like we have in America, I like to use SLT first because like Dr. Unger says, it takes the compliance out of the patient's hands and puts it in your hands by doing SLT. So, I think as we're shifting in the paradigm and you explain things, I have a lot of these diagrams in my office. The patients, when they can see this, they have a better understanding of what's going on, and then they can buy into incisional surgery a little bit earlier as well.
Good.
Yeah. I just loved your pictures of the dynamic videos of the trabecular meshwork and the aqueous pump. Those are just amazing.
That's from Murray Johnston. So I give all the credit. He's Mr. Dr. Trabecular Meshwork, Murray Johnston. So that's all him.
Yeah.
In that respect. So I give credit to him for those videos. And then Dr. Gold with the UBM and looking at the lens motion. And it's nice because you can better explain to people, and both to our colleagues and to our patients, and in terms of what we're seeing and what's happening. And, so it's really completely changed how I practice glaucoma over the last 25 years. Plus nowadays, cataract surgery is so much more safer now. When I was training with cataract surgery, we were doing large extracap wounds. The phaco machines were very clunky. We would get corneal burns. We don't have those things anymore. So, cataract surgery is about 5 to 10 minutes nowadays. Complications are much rarer. And as we move to, more successful cataract surgery with less complications, CME, we're seeing much less with topical steroids and non-steroidals. And so that's really changing the paradigm to really helping people save vision. But, we still need everything. We need the laser, we need drops, we need earlier surgery, because, these people who have glaucoma, they have damage to their trabecular meshwork. And once they have that damage, it's hard to reverse it. We want to try to intervene as early as possible to preserve that damage. But even despite the cataract MIGS, people will still, as they get older and older, the population is getting much older, they're going to eventually need medications and laser again as well.
Good point. Dan, I was surprised, with the results that SLT after MIGS can still be very helpful. Were you surprised at all?
That was really interesting. That really piqued my interest. When I saw Richard Lehre's presentation at ASCRS, I got a chance to talk to him about that as well. And, because I thought maybe these patients had already had SLT and maybe, the effect will be worn off. And so that was interesting. I'm actually planning to get this machine and do a study and look at that more in depth in my cataract hydrous patients and take a look and just see, where it's best to use it in that respects and offer that to patients as well. Because once again, it takes the compliance out of their hands, as Dr. was saying. So if we can do that, that's a good thing. So I want to look at that more in depth. So I look forward to that.
I did have another question for you about the patients, and I love that you did a study. I have done lots of SLT on patients after a MIGS surgery and found it successful, but I haven't done a study like you have, which is great. Did your study include patients who'd had a canaloplasty or a goniotomy as their MIGS, or was this mainly eye stents and hydrous patients?
No. These were not my studies. This was Dr. Lehre's study and another researcher study that published on eye stents, and both involved eye stents alone. I think to look at canaloplasty, That's
Yeah.
going to be, that's open. I think looking at hydrous is open. I mean, there's so many different types of MIGs and mixed combinations
Mhm.
that are going on out there. So I think this is a whole new area to look into to see, what works and what doesn't work.
Yeah.
That's a great point. What I thought underlines the safety of SLT is the data that's been gathered and presented on repeating the SLT. So in the light study, and I think other people, they've noticed that, repeating laser, the SLT, a second time can be very helpful. And
Right.
so that's causing me to rethink it. Originally, I would consider it if they had an initial response and then it failed. Now I've completely, changed that. Most people are worth at least a second opportunity.
Yeah.
Yeah. Jennifer, what's your experience been? Are you a big repeater or?
I haven't been a big repeater. I've usually said, well, if it didn't work the first time, it's hard to convince a patient that it's going to work the second time. That's been a roadblock, for my patients. But if I have, I think it's worthwhile based on the light study. Exactly. And the light study is great too, in that I think the results were slightly, like the risk of progression was slightly lower for patients who'd had SLT. And that's partly because it takes the compliance out of their hands and it's effortless.
And that underlines what, Dan was saying, maybe earlier treatment, but also, taking some of those elements out of the patient's hands. That with the light study, you had comparable intraocular pressure reduction, but the group that had the SLT had better visual fields.
Right.
So, good
Yeah.
point.
I would just
Good
add
evidence.
that the light study you have to be careful of, because those patients were mostly like ocular hypertension or had very minimal visual field damage, like maybe -2 dB was the average dB on the visual field. So that's very, very early. I mean, in my practice, my patients with coming in with glaucoma are really at like -7 dB. They're much more advanced. And so they have a lot more damage to the trabecular meshwork, may not be as responsive. And so that's why it's maybe easier to repeat in some of those earlier patients, maybe not as much in the later patients in that respect. And that's why I tend to intervene earlier with surgery, because these patients are coming in much more advanced in the light study in my patients in Harlem, New York City, and Southeast Queens.
Hey, Dan, when you have those patients that are more the moderate or even severe, but let's look at the moderate group. Are you reluctant to do an SLT?
Well, yeah, there was a study that came out of Duke, because most of these patients at more advanced glaucoma are usually required to be on 2 or 3 medications. And then when you have someone that's already on 2 or 3 medications, the effect of SLT on those patients is very minimal. That's been published, that's out there. So once again, I'm more in a surgical mindset when I'm dealing with, I mean, if someone's very advanced, I'm really jumping to trabeculectomy. The mild to moderate, I'm in the mixed category. And then I would consider, once I get their pressure down, if they need some therapy thereafter, then I would consider SLT because it's minimally destructive. It's pretty safe, and see if you could get an effect thereafter. And I want to look at that a little bit more in some of my post-surgical patients. That's what
I think with the safety profile, even looking at moderate patients, there's very little downside to the SLT. It depends on the functionality of the trabecular meshwork. It may be shot, and there's really nothing we could do with that.
Right.
One final point, there was a study that came out called the SALT study, and many people may not be familiar with it. And it was published in 2019, and it looked at post-operative management of people who had SLT. In the past, I have not used any medicines after laser because it's so comfortable. But the data suggests that if you use an NSAID or maybe even a steroid, that the long-term results are better after SLT. Do you guys have any comments or suggestions or ideas on that?
I use an NSAID after.
How long?
I use it for 1 week.
Okay. Dan?
And I'm not exactly sure what was the recommendation from the SALT study.
Uh,
Do
the big question was, does SLT work by an inflammatory mechanism?
right, right.
That using a steroid or an NSAID would perhaps block the effect. And they
Right.
found, just the opposite.
That it does not. Yeah, I prefer to not use a steroid because of the risk of a steroid response, of course. So I go with the topical NSAID for a week.
I just think it was done for a week.
Yeah.
Dan,
I
any
agree with
thoughts?
that. I agree with Dr. Unger. I don't use steroids because of the potential pressure spikes. And I will usually, depending on which NSAID, maybe I'll start at twice a day for 1 week and cut down to once a day for a week in that respects. More so just to minimize any discomfort.
Mm-hmm.
Thanks.
Good point. Well, we
Yeah.
can talk all night amongst ourselves.
Yeah.
Let me bring Keith back into the fold here and see if we can address any questions that the audience has. Keith?
Thanks, Dr. Barnaby. Okay, so from now on, let's go ahead and move to the Q&A session. We're starting to receive some questions from the doctors attending the live webinar. If somebody that is in the audience would like to ask a certain question, please look at the bottom of your screen where it says ask a question and send that on over to us so we can ask the doctors the questions that you're interested in receiving the answer for. So let's go ahead and start answering some of the questions. So I do have a question to Dr. Unger from the audience. Now you mentioned that you give 180 degrees of SLT shots for PDG patients. Do you have any other cases you especially pay attention to?
I usually do 360 degrees. In fact, I've done 360 degrees on PDG patients as well without any ill effects. However, I had noticed that there's a higher risk of a pressure response after, but no, I don't. I do 360 degrees on everyone.
And what about the 20% who don't get an effective response?
So the 20% who don't get effective response, we had talked about the possibility that repeating the SLT might be in the patient's best interest. And my plan is to move more toward that because that's been called to my attention recently. But I also, understanding the mechanism of SLT, it's mainly an outflow facilitator. Like most of our drops facilitate outflow. Even our surgeries like trabeculectomies and tubes facilitate outflow. There's less work on decreasing the production of fluid. And in that case, if I want to recommend another procedure for a patient, I might talk about micropulse laser, a transscleral micropulse laser, which I think is a really nice complement to SLT because it works by a different mechanism. And patients they can understand that concept that we like to not just increase outflow, but we can also decrease production as a way of controlling eye pressure.
Okay, great. Thank you for that answer. We also have a question here to Dr. Larouche. So Dr. Larouche, do you prefer to do SLT before or after cataract surgery and or MIGS?
My preference would be to do it after nowadays. Like I said, majority of my patients come in a little bit more advanced, and I like to address the mechanism of the glaucoma, which is in the majority of my patients, the enlarging lens, rubbing up against the iris, leading to pigment deposition. And with the results that we're seeing now after cataract surgery and MIGS, I like to do it afterwards. And actually, we're getting this machine now to look and do a study in that as well. So I look forward to, reporting those results sometime in the future.
Great, thank you, Dr. Larouche. So Dr. Barnaby, we have a question for you. Have you considered repeating SLT treatment in any patients? where there is a, let's say, suboptimal result or response?
Well, I would say, as of now, yes, I am. I think it's very much part of what I'm trying to do with the management. I think looking at the studies, and Dan was right, in terms of saying with the light study, a lot of the people had very, very mild glaucoma. But we haven't made people worse. And the surprising thing is they're better. And the only caution that I would share with you based on our results is it took us really about 12 weeks to see what a good or optimal response would be. And so before repeating, early on, I would wait at least 3 months or 12 weeks before we went ahead and did that. I think it's a completely viable and safe way of looking at laser as an adjunct and also as a primary treatment for our patients.
Great, thanks, Dr. Barnebey. We also have one other question from the audience in regards to your experience with the NIDEK laser, and they'd like to know really how has the NIDEK laser itself impacted your treatment of glaucoma?
Well, there are two things. One is the actual NIDEK laser, and the other one is the research and studies that have come out, and they're hand in hand. Obviously the randomized clinical studies show that laser is effective and it's safe. Using the NIDEK laser, it's been a very easy, smooth transition. It's a very comfortable laser to work with. I like the Navi system, and I think Dr. Unger did a great job of showing how well that can work.
Yeah.
And it's a very dependable laser.
Navi's good.
So all those things make it earlier to adapt. And what I think Dr. Unger said is, in terms of communicating to patients the best treatment, if a doctor believes in what they're doing, if they have good tools, the patients will sense this and they'll pick up on it. If there's any wishy-washy or any hesitancy, they'll pick up on that too. So I think that can't be understated enough, that having the physician be convicted, convict is not the right word. Convinced, sorry, my bad. But
we don't want to be
the
convicted.
physician's convinced this is what I would like to have myself. If I was in that situation, patients will pick up on it.
Yeah. Now, sometimes I do feel hesitant about it, in a patient who's had inflammation in the past, if they've had a questionable episode of an iritis. And I actually had one like that today. I've been seeing a lot of these patients lately. And I said, I'm open with my patients when I'm not feeling 100% on something. I said, last time I saw you, I thought maybe SLT would be a good option, but now I'm really not so sure if it's a good idea. You did have an episode of iritis a few years back, and this could stir it up again. So I would have to be convinced myself that it's safe to do that.
And I would underline that. I mean, I don't think SLT has been studied enough for people with uveitic glaucoma or people with, clearly neovascular glaucoma. That would be two groups that you may look and see the angles open and then automatically jump to a laser. And I'm not sure that's a good approach.
Right.
So thank you both for your response to that question. And we have one other question, and I think Dr. Unger, I don't know if you had touched base on this one other time before, but does SLT, does it work after a patient has had ALT? And this would be for all three of the panelists.
Does it work? I've done it, but not a lot of cases that were done after ALT. Sometimes I think after ALT, it might not work, especially if I look in the angle and I notice a lot of ALT typical scarring of the trabecular meshwork, because that can happen depending on how hot the laser was that was used to do the ALT. If I look at the angle and it looks like, oh, there's some mild depigmentation of the trabecular meshwork, but not necessarily the, the scarring. Sometimes you'll actually see some PAS from ALT all along the angle. I'll do SLT, and then I think it is more successful. So I've chosen my patients in that way, that I choose people who I think are going to be successful, and that has worked out very well for me. So yes, I feel comfortable treating patients after an ALT, even if it's failed.
Great, thank you. Makes sense.
Mhm.
So I think we have time for maybe one more question, and this is going to be directed to Dr. Larouche. When or under what type of conditions do you perform SLT for patients who have had phaco surgery and MIGS?
Well, like I said, after they have phaco and MIGS, at some point down the line, they usually sometimes will need an eye drop or laser treatment. And then that's when I'll have the discussion to offer them. If their pressure starts to drift up from 15 to 18, 19, 20, 21, I'll say, okay, the pressure's starting to creep back up, and we may need to add something else to that. And I'll have that conversation. And so that's when I'll offer them that. And depending on the patient, most patients are willing to do a laser treatment thereafter, because once again, they don't have to take the eye drop. Some who may not fully understand may want to start with one eye drop or two eye drops, but then if that becomes a little bit burdensome, we offer them a laser again, and to have them try and see how they're doing. And so that, is another opportunity to offer them a laser.
Thank you, Dr. LaRoche. And just one more question for you, the panelists, and this will be directed to Dr. Barnebey. Do you think that SLT works better when it is used as an initial treatment?
Yeah, the short answer is yes. I think, the earlier in the disease, potentially the more functional the trabecular meshwork is. And I don't think that the routine use of medicines in terms of trabecular meshwork function is good. So if you're going to try to revitalize a system that is compromised, but it's not shot, then I think the best opportunity is in the beginning.
Mm-hmm.
Yeah, Dr. Unger, do you have the same type of response to that question?
Yes, I feel exactly the same way, particularly my patients who are younger. I usually encourage them more toward having SLT treatment, earlier in their life rather than later, because they've got a lot of years ahead of them. Eye drops have all kinds of side effects. And yes, the SLT does help address the trabecular meshwork. You know what I want a video like Dr. LaRoche's video that shows the unhealthy trabecular meshwork, and then the trabecular meshwork after the SLT that shows it's improved. I'm not sure if that exists, but I think that would be great to see.
No, I haven't seen that video yet.
No, I mean, yeah, we'll make one. Let's make one.
Well, thank you all for your responses to the questions, and I want to thank you for the many questions that have come in. But it seems that we are now running out of time. So let me go ahead and conclude this live webinar. We would like to express our deep appreciation to all three of the doctors, and also Dr. Howard Barnebey for being our moderator today. And we would like to thank everybody who has attended the live webinar as well. I hope you have a deeper understanding of different diagnoses and management of glaucoma, different techniques, different styles, and also utilizing the NIDEK YC200S Plus YAG SLT system. So again, I want to thank you very much for your kind attention for this webinar, and please enjoy the rest of your day, your evening, your night, wherever you may be. Thank you.